Association for Behavioral Health Providers. Tracy Tinker will be our presenter. I'll introduce her in a moment. First, just a real couple quick housekeeping things that you've all seen. In order to get any continuing education, you must sign this roster. I'm going to pass it around the room. Thank you. So for CE sessions, the roster's going around. A survey monkey will be emailed to you. You can also find the link on the conference website. Please try to complete the survey within 2 weeks, and then the certificates will be emailed to you at that point. For those of you that are here that are interested in CME or nursing credit, there is a simple process here as well. This yellow sheet, there's more by the door, explains the CME process. Basically, log in to the SurveyMonkey link. We ask that you try to complete this by the end of the week if possible, but we will work with you. Same thing, your certificates will be emailed to you within about a month after completion of the evaluation. Can you get a phone? If you do, there'll be 2 separate evaluations. So Diane and the NADIC staff, they'll email you their eval, and then there's a CME evaluation. Thank you. There are no conflicts of interest for this presentation going on today. The other thing to remind you all that this session is being recorded because we are, for the idea and training track, wanting to have it available to others that aren't able to join us. This quadrant right here, there is a speaker, a microphone right above your head. We ask that you all just help us to mitigate the noise as much as possible. Handouts, as well as the recorded webinar, will be available on the North Country Health Consortium website. Webinar might take a few weeks at least. We'll try to get the handouts loaded within the next week or so, give or take. Thank you. So, to move forward with a quick introduction, Tracy has been a nurse case manager at an integrated healthcare for the homeless program of Catholic Medical Center in Manchester, New Hampshire for 8 years. As a certified diabetes educator, she is passionate advocate for client-centered goal setting for her clients with diabetes and prediabetes, helping them to successfully achieve their self-management goals. In 2013, Tracy worked on a multidisciplinary team partnering with the National Healthcare for the Homeless Council to update diabetes adapted guidelines to help address the special challenges that homeless clients face to manage their diabetes successfully. Without further ado, Tracy Tinker.
Thank you. So what I hope to do today is share with you both some anecdotal information of my experience working in an integrated healthcare system with integrated behavioral health and medical, as well as share some data with you as well. When I was asked to start working on this presentation by the IDN4, the Medicaid waiver, I quickly realized how blessed I was. Working as a medical person, I don't know, and working as a nurse, I don't know what it's like to work as a nurse in a place that doesn't have integrated behavioral health. I'm really spoiled. If I have a patient that comes in and we pretty quickly can recognize that that person could benefit from seeing behavioral health, I have behavioral health staff right in the clinic. We can do a warm handoff and introduce that person right away. Until I started going around speaking about integrated behavioral health, I really didn't realize that not everyone operated that way. I hope to show you today why integrated health is so important. One of the things I like to start off with is data that all of you in the audience, I'm sure, are extremely familiar with. And that's the large study in around 2006, where they showed that patients who have significant mental illness die 20 years earlier than the general population. It's now 2018. That was kind of a long time ago. You would think we should be a lot better at this. Back in 2017, the World Health Organization said we should look and we should see improvement in this. Unfortunately, people with significant mental illness still die 10 to 20 years earlier than the general population. They're not dying, for the most part, from mental illness. Shout out, tell me, what do you think that the majority of people with significant mental illness are dying from? Exactly, up here, Mary. Cardiovascular disease. Just like the rest of the general population, patients with significant mental illness are primarily dying of cardiovascular disease. It makes sense that having integrated care, behavioral health, and medical, we should be able to impact this. Today what I hope to do first is share with you some of the latest guidelines. And I picked 3 of the most common chronic diseases to talk about: diabetes, high blood pressure, hypertension, and high cholesterol, or dyslipidemia. I want to share with you the latest guidelines, and then talk about the intersection of chronic disease and behavioral health. Then we'll move on to talk about some of the barriers to integrating the two, and then identify and utilize strategies to overcome the barriers. And the way we'll do this is we'll do an overview first, talk about the intersection, talk about barriers, some solutions to the barriers, and then bring it all together at the end with a case study. If you've got questions or comments as I go along, please feel free to raise your hand and we can take questions as we go along. So here's the problem. As we know, people with mental illness are dying earlier than the general population. 68% of adults that have mental illness also have a chronic medical condition as well, and may or may not have a primary care provider. And 1 in 5 patients with mental illness also have a co-occurring substance use disorder. These are the specifics of the cardiovascular diseases. If you notice, most of these are cardiovascular diseases. People with mental illness have a higher prevalence of high blood pressure, a higher prevalence of heart disease, a higher prevalence of diabetes, and a higher prevalence of obesity, all cardiovascular risk factors. Also have a higher prevalence of behaviors that lead to cardiovascular disease, like smoking, and a higher prevalence of asthma. These graphs look at the prevalence of depression in green and diabetes and high blood pressure or hypertension in red and blue. This is overall in the US from 2013 to 2016. As a medical person, I was very surprised. I did not realize that the prevalence of depression was much higher than the chronic diseases that we see every single day in our clinic. And the unfortunate news is if you look for over 2013 to 2016, the trend in the curves is rising. Where do you think most people are receiving their depression care? At the primary care provider, exactly. If you look at the data, 70% of depression is treated in the primary care provider. If the primary care provider refers outside to mental health, what percentage of people go? 10%, exactly. The data shows 10%. So if you're a primary care, you identify depression, and we'll talk a little bit about how we're screening in the primary care office for depression, and you make that referral, only 10% of the people actually show up. So here's making a case for integrated health, hopefully improving those rates of people actually showing. This is for the US. This is for New Hampshire. The curves look almost exactly the same. It's just the magnitude of the numbers that differ. Okay. I'll move around. I'll move over here. So this is a little bit busy, but these are the ADA guidelines, the standards of care for 2018. Every year, the American Diabetes Association puts out what they call their standards of care. And this is who should be screened for diabetes. If someone is screened, they screen positive, they have diabetes, how should they be treated? What medication should be started? What medication do you start next after somebody fails the first medication? These are updated every single year, and in January, they come out with the latest guidelines. So in 2019, January, next month, we'll have the 2019 guidelines. What was very interesting about the guidelines for 2018, first, there's very large mention right at the beginning of the guidelines of social determinants of health. Remember, these are medical guidelines, and the audience for these are medical people. And they're actually talking about social determinants of health. I think that's a really interesting trend, a really important trend, that for those of us on the medical side, we're starting to recognize what you all have known for a long time, that people's health is not just affected by their medical health, it's also affected by their social determinants of health, their housing, their access to care. The guidelines for 2018 define who should be screened for diabetes. The first large population that should be screened for diabetes is anyone who is 45 years of age or older should be screened with either a fasting glucose or with an A1C. So an A1C is a measure of the percent kind of sugar coating on your red blood cells. So your red blood cells live for 3 months. They circulate around your body. The A1C test can measure the thickness of that sugar coating. It's like if we could measure the thickness of the sugar coating on an M&M. If someone's sugar coating is between 5.7 and 6.4, that puts them in the pre-diabetes category. Pre-diabetes is very important to recognize. If you can diagnose someone with pre-diabetes, you can intervene before they develop diabetes. Once someone goes on to have diabetes, you can intervene to make sure that their diabetes is in good control, but they always have that diagnosis of diabetes. If you can intervene at the point where they have pre-diabetes, you can actually have that person go back into the normal range by making some lifestyle changes. So we actually screen everyone over 45 in our population, and anyone with a body mass index of greater than 30, or if they are of Asian ethnicity, greater than 25. And one cardiovascular risk factor. the cardiovascular risk factor that we have chosen to screen for is hypertension or high blood pressure because such a large portion of our population has high blood pressure or hypertension. So anyone 45 and older gets screened. Anyone who has an elevated BMI and hypertension also gets screened. If you get screened once and your A1C or your blood sugar, your fasting blood sugar is normal, we screen you again in 3 years. If you're pre-diabetes, we screen you every year. The recommendation from the American Diabetes Association is also to screen any woman who had gestational diabetes or diabetes during their pregnancy. That puts a woman at a higher risk of diabetes, so they should be screened as well. These are the numbers. If someone is between 100 and 124, that indicates pre-diabetes, a fasting blood sugar of 125 or above, diabetes. The A1C, if you are between 5.7 and 6.4, indicates pre-diabetes. If you are 6.5 or above, diabetes. We have the ability in our clinic to do what we call point of care testing. So we can measure their A1C while they're in the clinic and intervene right there. Which, because we have a fairly transient population and a population where transportation is a huge barrier to getting around the city, being able to test right in the clinic versus sending someone to Catholic Medical Center or Elliott Hospital for that testing makes a big difference. In the past, before we started doing point of care testing, you'd give somebody the lab order, they might go, they might not. And then even if they went and you got the results, then you can't find them to give them the results and intervene. So this way we can do the A1C. We do A1Cs every 3 months in people with diabetes. We use it for the screening test as well. And then we intervene right away. If they need changes in their medication regimen, we can do that right while they're in the clinic. The diabetes guidelines are fairly clear cut. It's this number versus that number. The high blood pressure guidelines, there is a lot of controversy on these guidelines right now. So, historically, the guidelines were determined by this group called JNC. And they set the guidelines for high blood pressure at 140/90. And it was that way for many years. In 2017, the American College of Cardiology and the American Heart Association lowered the guidelines and said we should call hypertension anyone with a blood pressure over 130/80. What this study shows is that if you make that change and you define it as 130/80, you're going to have an increase of 31 million people that you diagnose with hypertension. There is not, at this point, clear-cut data that shows for the general population, if you lower someone's blood pressure from 140/90 to 130/80, that you have a huge impact on their health. So you're now taking 31 million more people, putting 31 million more people on medications. Medications can have side effects, as we all know. So there's definitely a lot of controversy right now. In October, there's a very large cardiovascular meeting held in Boston every year called the Cardiometabolic Health Conference. There was a lot of talk at that conference about these guidelines and whether they should be lowered or not. I think what you're going to see over the next few years is this is going to change. It's going to be lowered to 130/80. And our clinic, we're a federally qualified health center. So we have a lot of quality improvement measures that we have to meet and report on. So for right now, the feds tell us, you need to report on 140 over 90, but I could see in the next few years that's probably going to change, and we're all going to start seeing 130 over 80 and above defined as hypertension.
I have a question about
Sure.
that. How much influence do you think is being pressured from the pharmaceutical companies on that decision?
The question is, how much pressure is there from the pharmaceutical companies on that decision? I haven't seen studies that quantify it, but I would imagine that that's definitely, I'm sure, going into the equation. Yeah. The other thing that I thought was very interesting about this cardiometabolic health conference, it's a very interesting conference because you get all of the thought leaders from across the world that come to this conference in Boston, and they hold it every year. What was missing from this conference that I noticed is there is almost no discussion of the link between cardiovascular disease and mental health. Everyone who's presenting at the conference, they're medical people. They're thought leaders in cardiovascular disease. They're thought leaders in hypertension. There's very little recognition right now of the link between cardiovascular disease and mental health or behavioral health.
Did they bring up oral health? Because I find in a lot of our mental health patients, there's no oral care. There's always a concern whether that is exacerbating their chances of the fact that they have such stuff going on. I don't know.
She's asking about the link between oral health and cardiovascular disease. It came up a little bit, but I can share it. In our clinic, that's a huge need. Especially, we work with an underserved population, so not surprisingly, dental is hard to access, but a huge need.
It's also not really covered by Medicaid, but the only
Extractions.
extractions are covered, so that's probably one of the reasons.
Just stating that one of the reasons that it's hard to access oral health is Medicaid coverage, and yeah, we see that as well. It's basically extractions. Okay. So moving on from high blood pressure now to high cholesterol or dyslipidemia. In 2016, the USPSTF, which is the United States Preventive Task Force, so the USPSTF, they're the people from the feds that give us the guidelines on things like colorectal cancer screening, right? Everybody over 50 should have a colonoscopy. That comes from the USPSTF. The lung cancer screening, anyone who is 55 or older and has a 30-year smoking history should be screened with a low-dose CT scan for lung cancer. Those are the kinds of things that come from the USPSTF. What they did in 2016 is they took the old guidelines for dyslipidemia or high cholesterol. Used to be you should have a good cholesterol of this and a bad cholesterol of this and a total cholesterol of this. And they said, that's not as important as knowing who's at risk of a cardiovascular event. So we're going to change the guidelines from these are the numbers to let's identify who's at risk of a cardiovascular event. And then if you are at a risk of cardiovascular event, we'll make a recommendation around statins and who should be on a statin. The recommendation now is anybody adult who is 40 to 75 with no history of cardiovascular disease, CVD, but who has greater than equal to 1 cardiovascular risk factor and a calculated 10-year risk of cardiovascular disease greater than or equal to 10%, you should be on a statin. This sounds complicated, but it actually isn't. There's a whole bunch of apps now that very easily calculate this cardiovascular risk. They're free apps, you can download them. There's one, ASCVD, You download that app, you plug in a couple of numbers like what's somebody's blood pressure and what's their cholesterol, things, different numbers related to cardiovascular risk, and it will spit out for you what their percentage risk of cardiovascular disease is. So they broke it out to anybody with a cardiovascular risk of 10% or more should be on a statin. Anyone with a cardiovascular risk of between 7.5 and 10 should have a risk-benefit discussion with the provider on whether they should be on a statin. So I thought this was interesting that when they wrote these guidelines, they actually changed the clinical question from here are the numbers to who's at risk of cardiovascular disease and let's intervene with a statin to treat it. This also comes from the American Diabetes Association, the ADA. And they actually have a section in the guidelines about psychosocial screening. So this is to help guide providers on who should be referred out for behavioral health. So anyone who has an A1C that's elevated, so above, what we usually call elevated is 9%. The guidelines really, you want somebody about between 6.5 and 7. Because we have a higher risk population, we usually use 9, we call that a high A1C. And that is based on some data around complications and when the complications happen. If you've worked with that person, they've seen a diabetes educator, and they're not having a decrease in their A1C, that's a good person to refer out for mental health. The other disease that can coexist with diabetes is people with diabetes have a higher risk of having what do we call it? Bulimia, eating disorders. So anyone who you have screened who you feel might be at risk for an eating disorder is a good referral out. And then even people, if they are telling you that they're having difficulty managing their diabetes, that might also be a good referral.
Are these people getting screened for substance use, alcohol use, and other things?
Yeah, and I'll talk about that in a little bit. Mary's question was, are they getting screened for substance use disorder? I can tell you in our clinic and in New Hampshire, if you are getting any grant money from the state, you do have to perform a NIDA screening on all patients, and then you should be using SBIRT, screening, brief intervention, referral to treatment as well. And that is happening. In our clinic, we screen everyone once a year, and if they're coming to us for a substance use physical, we'll usually do a NIDA as well. About a year and a half ago, 2 years ago, our clinic changed from using a PHQ-2 to a PHQ-3. Is there anyone not familiar with a PHQ-3?
What's the third question?
Perfect. So the PHQ-3 is the usual question to ask for a PHQ-2, and question 9 on a PHQ-9, so the suicide question. We have a fairly high-risk population. We decided it would be better, and along with the Zero Suicide Initiative, that we should be screening with a PHQ-3. So we screen everyone with a PHQ-3 once a year, and anyone who's coming to see us for a physical for substance use disorder treatment, we also screen in that case as well. What's interesting about that, and here's one of the places where I realized that working in an integrated clinic is a little different than a not integrated clinic, is we're part of a group in New Hampshire that all use the same electronic medical record called CHAN. And CHAN is a group of different federally qualified health centers. There's a couple of other healthcare for the homeless programs that are part of this group as well. We went to Chan. When we need to make changes, we need to go as a group. We all decide, yes, we want to make a change to the electronic medical record. So I sat on that committee. I brought it to the Chan committee of other federally qualified health centers and said, I think we should be changing to a PHQ-3, and how can we set up the electronic medical record to easily capture a PHQ-3? The other health centers said, whoa, wait a minute. We don't want to do a PHQ-3. We want to stick with our PHQ-2. Why do you think they were concerned about changing from a PHQ-2 to a PHQ-3? They didn't want to know the answer. Exactly. It's not that they didn't want to know the answer. They were afraid of the answer. We're integrated. If someone answers something other than 0 on question 3 or question 9, I can go down the hall and grab Lisa. She's my licensed clinical mental health counselor. I can go down the hall and grab Jen. She's an MLADAC. I have Brian. He's a master's prepared social work. I can go grab somebody and say, hey, I'm really concerned about what this person is saying. Could you come in and meet with them? They don't leave our clinic until we've assessed that fully. Other primary care offices that don't have integrated behavioral health, the front desk person might be handing the person the PHQ-2 or the PHQ-3. The patient fills it out. They might look at it a day or 2 later. I can see where that would be very risky. So, to me, I brought this question forward. I had no idea that would be what the response was. So where we are now is our clinic is doing PHQ-3s. The other Chan places are doing PHQ-2s still. The other thing that we've started, and I'm working on a project with Lisa, she's our licensed clinical mental health counselor, is to do a DDS-17. Has anybody heard of the DDS-17? No? Okay. This is a diabetes distress score. This was developed by a psychologist in San Diego named Dr. Polanski. And this measures 4 different domains. Is my regimen for diabetes so complicated that I don't feel like I can do a good job? Is my diabetes so overwhelming that I have emotional distress around my diabetes? Do I not have anyone around me who supports me in my diabetes? They're telling me to eat the wrong foods. They're not helping me exercise. And the 4th domain is I don't trust my healthcare provider, and I don't think I have anybody for a healthcare provider that can help me with my diabetes. It's a series of 17 questions. We have it either on paper or on a tablet. The patient fills it out either with myself as the certified diabetes educator or with our licensed clinical mental health counselor. And depending on the response, if they score 2 or higher, which has been shown to be clinically meaningful, they have a referral either if it's regimen distress or they don't trust their provider, they have a referral to me to talk more detail about that. If it's emotional distress or interpersonal distress, they see the licensed clinical mental health counselor. What we found with this is if I administer the tool and I say, oh, you're scoring high, I'd really like you to see one of our behavioral health team. Oh, I'm fine, I don't need to see anybody. But if I actually invite Lisa in while I'm seeing the patient and do a warm handoff, I can transfer the trust that the person has with me over to Lisa. And vice versa, if Lisa administers the tool and wants to refer to the diabetes educator, I can go in and we can do a warm handoff. So we talked to Dr. Polanski, who developed the tool, and because we wanted to know how other places were actually using this. And he said he's the developer of the tool. He gets referrals from other primary care offices to him. Guess what his percentage of people showing up when they were referred from the primary to address their diabetes distress? I wish it was 10. It was 5%. He said, I'll come to your primary care office and sit in the waiting room. Administer the tool, I'll meet with people. Just give me a space to meet with them in your office. None of the primaries took him up on it. So Lisa and I really enjoyed talking to Dr. Polanski because he was happy to hear that there was somebody that was actually using the tool and having a lot of value from the tool. So we just started doing this about 6 months ago. We do have a report where we're gathering data to make sure the referrals are happening. So this is kind of a work in progress right now, but both Lisa and I are very excited about the opportunity to address specifically diabetes distress. And I think because we're integrated, it offers that unique opportunity to really address both sides of that. Not only is there a link between behavioral health and chronic disease, but unfortunately some of the medications have a higher risk of weight gain and diabetes. So these are second-generation antipsychotics, and you see that they have varying degrees. The pluses, the number of pluses indicate the risk of weight gain and diabetes. A couple of the kind of known medications that can cause, and I'm sure you've seen this in your practice, the weight gain. First is Zyprexa or olanzapine. And anecdotally, one of the medications that we've seen that's often causing a large amount of weight gain, and we've seen some people actually develop diabetes, is Seroquel or quetiapine. So, sort of the message from this slide is, the patient needs to be prescribed the medication that's going to work for them. But, if there's a different medication in the same class that might work for them, but cause less weight gain in someone who already has a risk of diabetes, can you look at those medications versus the ones that have a higher risk? And the American Diabetes Association and the American Psychological Association got together a few years ago and said, here's a protocol on how you can monitor patients on second-generation antipsychotics to look for weight gain, high blood pressure, high cholesterol. This is fairly easily done in an integrated clinic because you've got the medical people that can order. They're taking the blood pressures. They can order the lab tests that need to be done. Maybe less easy to do somewhere where you don't have medical people on staff. The other piece to this is sometimes the medical provider, even if the person has a PCP and they go to the PCP, some primary cares are reluctant to order the testing because they didn't put the person on the medication. I could actually spend the next hour and a half talking about medication reconciliation, but I'm sure all of you probably have as many stories as I do of times when somebody came and the medications weren't reconciled. You didn't know they were taking this, you didn't know they were taking something new. They didn't tell you they stopped the medication, so this is actually a whole nother talk on medication reconciliation. The weight gain and diabetes risk is actually not unique to the second-generation antipsychotics. It's also found in some of the antidepressants. I find it very interesting that amitriptyline has a secondary indication for treating diabetic neuropathy, but it's one of the culprits for causing weight gain and diabetes. Talked about this a little bit earlier. This is who do you refer and when do you refer to behavioral health, so I'm going to kind of skip over this slide. So what's the solution to the problem and the questions? And that's integrated care. I'm going to share some data, and the data looks at both integrating behavioral health into medical and integrating medical into behavioral health. This is a really busy slide, and I know you probably can't read much of it in the back, but what I want to use this to talk about is levels of integration. So about 6 or 7 years ago, when we started kind of this work around integration, we thought the goal was to move everything to full integration, and that we were on this continuum that we would move to full integration, and that's where we wanted to be. When the IDN board came to us and said, we want you to look at integration, we want you to put together integration plans, we very quickly realized that that really isn't our goal. Our goal is to integrate along all levels. So the three kind of large buckets of this are fully integrated. We have a licensed clinical mental health counselor, we have a MLADAC, and we have a master's prepared social work, and we have an opening right now for a CRSW, a recovery support worker. We are all employed by the same people, the medical staff and the behavioral health staff. We all work in the same electronic medical record, and we meet once a week, actually on Tuesdays at noon, to do case management with the medical team and the behavioral health team. That's really where our full integration lies. We do full integration really well. We also have co-located integration. So we have a nurse practitioner, mental health, that comes from Manchester Mental Health once a week. He works in our electronic medical record, but he's employed and under contract to us from Manchester Mental Health, co-located. We also have a path worker from Manchester Mental Health who works in the clinic but does not work in our medical record, and he helps connect patients that are requiring a higher level of care than what we can satisfy, connect them for that higher level of care through the Mental Health Center of Greater Manchester. So co-located, we have kind of two levels. Where we really need to work on for our clinic is the referral piece, the referral integration. So we make a referral out because someone's requiring a higher level of care. Most of the time that referral out is to Mental Health Center of Greater Manchester. They may get there, they may not. They may connect. It might be that the path worker is there that day and they can meet with the path worker there that day. They're much more likely to get connected. If Matt, who's our path worker, isn't there, oftentimes by the time Matt goes to try to find them or we're trying to find them, we can't find them anymore. Or they may even make it to their appointment at the Mental Health Center of Greater Manchester, but we didn't get any notes back, so we didn't know they actually went. So we really want to look at a closed loop referral process, and this is for all our referrals, not just our behavioral health referrals, so that outside agencies actually have access to some information in the electronic medical record. We're not faxing a piece of paper that is getting lost, and they can document somehow that comes back into the electronic medical record so we know they went and there's an integrated plan of care. So we're using our IDN monies to improve that closed loop referral process. We're also using some of our IDN monies to, there are 2 mental health workers, with both our nurse practitioner and our licensed clinical mental health counselor have an interest in diabetes. So the American Diabetes Association actually has a database of people who have expertise in both areas. So they are working on getting recognized as having that expertise. So those are a couple places where we're using some of the money that we're receiving from the IDN. So here's the data part. Doesn't work. So I've got 5 studies up here looking at different things. The first study was done in 2011 and looked at both quantitative information. Did their A1C improve? Did their blood pressure improve? So quantitative information around their medical information and qualitative information around their depression symptoms. And what they showed was using nurse case managers who were working on both the medical side and the behavioral health side, working with providers from both areas, they could improve care, improve qualitative numbers, improve quantitative numbers, improve qualitative symptoms of depression in both groups. I'm going to save the Bogner study and show you some really interesting data kind of on the next slide. Goodrich wanted to know, okay, if you can do this, but is it cost effective? And yes, indeed, they were able to show cost effectiveness. Butler looked at different levels of integration. Did it matter if you fully integrated, co-located integrated, a mix of both? And what they found was there was improvement in symptoms, both medical symptoms and behavioral health symptoms, regardless of the type of integration you did. So it didn't matter what model you used, you still had improvement. And I just included this last study because it was almost brand new from 2018. They looked at the nurses, behavioral health people working in the integrated clinic and showed that there was an improvement in the perception of the people who were working with patients when they were operating in an integrated care system. So on to Wagner. This study looked at if you could improve the way someone took their blood pressure medicine, would they improve in taking their depression medicine? And they saw a huge impact. So if you were operating in usual care, 31% of the patients were actually adherent to their medications. That's only a third of people were actually adherent to their medications. Integrated care, 2/3 of the people were adherent to their medications. And if they were adherent to one medicine, their medicine for hypertension, they were adherent to their depression medication as well. And I think we see this every day working with patients. If you improve their adherence in one area, it improves overall. And when I talk about the case study, I think you'll see where that kind of, the rubber meets the road, where that really happens. So what are some of the barriers to having this happen? When I was putting this together, I spoke with some of our behavioral health team, and we were remembering some of the times where sometimes we speak a different language in medicine than the behavioral health team speaks. We're constantly reminding each other in meetings about saying things like using stigmatizing language like diabetics. No, they're people with diabetes. Or schizophrenics, people with schizophrenia. So we try to stay on top of each other and correct each other. So this sort of the second one was kind of a funny. One day the behavioral health team was getting together to do supervision. So as nurses, we wanted to know what they did wrong. Because if we're being supervised in nursing, it means something went wrong. We don't do supervision because it's what we do and it's part of our practice. So our behavioral health team explained and corrected us. This one was one of my examples, the triage, and that's not my scope of practice. We had a social work nursing student, a social work student from UNH, and it was a really busy clinic day, and I was one of the only nurses in the clinic. So I said to the student, somebody just came in, could you go triage them? And, because I'm really busy. She went to the behavioral health supervisor and she said, she's asking me to triage, that's not in my scope of practice. When I asked her to triage, my thought was, could you just go ask the person why they're here? Find out if it's behavioral health, could you sit down with them? If it's medical, just let them know I'll be with them in a minute. She interpreted it as I was saying triage, and that was not in her scope of practice. So sometimes it's just the language we use when we talk to each other that we're not really speaking the same language. We learn that over time, and it still sometimes happens that we're speaking the different language, but we usually can clarify that pretty quickly. Physical proximity can be a large one too, both positive and negative. For us, like I shared earlier with our PAC worker, the days that he's in the clinic, we do much better at connecting people with Mental Health Center of Greater Manchester. When Matt's not in the clinic, we don't really have a great process for how are we going to make sure when Matt comes back to the clinic, this person gets connected with him. We still struggle with that. We've tried different things. We've tried calling directly to Mental Health Center of Greater Manchester to schedule an appointment. You're laughing.
From Greater Nashville, we're doing, we have to say they call us and try to connect, we call them and try to connect them around the phone.
Yeah, and you can't reach them, or they don't have a voicemail set up, or they're there and there's no appointment for a few months, and so it's just, it doesn't work very well. So physical proximity can make a big difference. Certainly differing treatment goals and priorities. I want to share a story. There's a patient that, as a nurse, I've worked quite extensively with, and one of our licensed clinical mental health counselors and social work has worked extensively with. He frequently comes in with piles of paperwork, and that's why he's there. He doesn't really care about the medical so much. He wants help with the piles of paperwork. So one day he came in with a pile of paperwork, and he told the licensed clinical mental health counselor that he was having chest pain. So I went over to see him, and he was short of breath. He was having chest pain. He was starting to get a little sweaty. I'm like, I'm calling 911. You gotta get out of here. I called 911. The EMTs came very quickly. The EMTs were trying to walk him out of the clinic. They could not get him out of the clinic because he's walking up to the licensed clinical mental health counselor. You gotta take my paperwork. This has gotta be addressed. You gotta do my paperwork. You gotta go, you got chest pain. So his priority clearly was not the chest pain. His priority was getting the paperwork. My priority was getting him out of there into the emergency room. So sometimes the patients have different priorities, sometimes the behavioral health has different priorities as well. So it's kind of managing those different priorities as well. I mentioned a little earlier medication reconciliation. This is something that is huge in healthcare, behavioral health right now. Right now, this is something that Catholic Medical Center, even as a hospital, is looking at ways to address. It's difficult. Even calling the pharmacy, you don't always get a correct med list. It's difficult, but it's also extremely important. As a primary care office, we need to know what medications that person is on. And behavioral health, you need to know what medications. If you're going to start a medication, you want to be able to run an interaction against that medication. So I wish I had some really good solutions to this. We do, for every patient who is new to us, we will always call the pharmacy to get a med list and when did they fill stuff last. So we do try to start with a clean med list, and we try to encourage people to bring all their med bottles in with them at every appointment. And we schedule follow-ups fairly short term for certain medical conditions so that we shouldn't be getting calls for refills because they've got that follow-up appointment to address the refills. Social workers, psychiatrists, medical, we all have different education. So it's kind of trying to marry those things, and we all have different scopes of practice. We often struggle with working to the top of our licenses. That's where we really want to be working. Definitely try and work on all working to the top of our licenses. How many of you have lots of workarounds going on? Doesn't work, EMR is not working, we're going to try to work around. We're trying this process, we're going to create another way of doing it because this doesn't seem to be working, but we didn't write it down and we didn't train the new person on the workaround, and that kind of stuff happens all the time. We are trying, I will say that we all know the language of PDSAs. Does anybody know PDSAs, right? Plan, do, study, act. Small tests of change. We are all about the small tests of change. So we will very, very frequently, we don't have all the answers when we're rolling something new out. So we'll do a small test of change, make another change, another small test of change. And obviously technology is critical. Our EMRs unfortunately don't talk to each other. It makes it very difficult. This is an article that was published in 2017 looking at, the theory was 42 CFR Part 2. Is everybody familiar with 42 CFR Part 2 providers? So this is another area where we are still a work in progress to create a 42 CFR Part 2 compliant release. And then we have we see about 1,700 unique people a year. Our medication-assisted therapy program is 7 people. So we're trying to work on how do we account for the 7 people and the 1,700 people and make sure that we're not releasing things. And as we go to more electronic and there's not a person that's looking things over, this becomes even more of an issue, making sure that we've got the right release in place. Where we're going to end up on this and where we're working towards is everyone is going to sign a 42 CFR Part 2 compliant release so that we don't inadvertently disclose when we go to more electronic sending records. So let me talk the case study. This is a 56-year-old male. He has a history of type 2 diabetes. He's got a couple of different kinds of neuropathy. He's got something called orthostatic hypotension. So when he stands up, because the nerves that tell your body that you're standing up are affected by his diabetes, he often falls down or faints. He also has diabetic neuropathy, so he's lost a lot of the feeling in his foot. And he has a history of substance use disorder and a history of schizophrenia. This gentleman, when he took aripiprazole or Abilify. When he takes the Abilify, he does extremely well. He can manage his diabetes. Really speaks to the medication adherence. If he was adherent to his mental health medications. He was adherent to his medical medications, his diabetes medications. When he would go off the mental health medications, because he would start to feel better, guess what happened? He went off everything, kind of the plan all fell apart. So he was diagnosed with a foot ulcer, and he was hospitalized. The foot ulcer had actually spread to the bone, so he had osteomyelitis. And he received antibiotics at the hospital, and they discharged him and told him no weight bearing, so that he couldn't be walking on the foot. They discharged him to the shelter. Anybody see a problem with that? Well, he walked to the shelter, but what is he going to do all during the day? He's going to walk around. He's going to walk around the city, right? So that's exactly what happened. And they asked him to quit smoking. They gave him prescriptions for his insulin, for his mental health medications. He gets, his income is actually from Social Security disability. It's the end of the month. Why is that a problem? He's out of money. It's the end of the month. So they actually, this actually really happened, and he did not have a safe place to go because he was staying at the shelter. So what happened was, obviously, he was readmitted. One time, he got discharged. He walked on the foot. The foot started bleeding. He ended up within 2 to 3 hours, he was back at the emergency room, and now he required a transfusion because he had lost so much blood from walking on the foot. He did get hospitalized at one of the local hospitals, and they kept him for 2 months to do IV antibiotics. And I actually went to visit him while he was in for the 2 months. They rolled in a TV, they gave him a bunch of DVDs. He was happy sitting in there watching DVDs. Pretty expensive care though, right? Acute care for somebody who really didn't need it. But why couldn't he be discharged to a skilled nursing facility for the IV antibiotics?
He might not have had insurance.
He has Medicare.
Skilled need.
He's homeless.
So she was saying he couldn't participate in the rehab because of his non-weight bearing. Probably not. He probably could have still gone.
I'll say fear and stigma.
Fear. So tell me a little bit more about fear and stigma. What does that mean?
Well, that he has a major mental health
Mhm.
diagnosis that has a lot of stigma attached to it, and people believe that people with schizophrenia are often violent, which is not true necessarily. And so I think that they will refuse to admit people with that diagnosis.
That was definitely part of it, fear and stigma. I did hear somewhere someone said he was homeless.
Yes, they won't accept him if he doesn't have a place to go. Disposition is an issue.
Exactly. He was homeless. He doesn't have a place for the skilled nursing facility to discharge him when he's ready to be discharged. So they can't discharge to the street, so they won't take him because there's no safe discharge plan at the end. That's exactly what happened. The hospital, it's a little different in the hospital, yes. Yeah. So unfortunately he was 2 months. Then he moved out of the area. He went down south. So when he moved out of New Hampshire and went down south, his Medicaid got changed from New Hampshire Medicaid to where he was. Unfortunately, he did end up having an amputation at that point and came back up to New Hampshire. And we actually didn't know he was back in the area until he ended up back at the hospital because he ran out of insulin. So what happened?
That's segmented, he's not taking his insulin.
Probably not taking his segments, but the biggest thing was he didn't transfer his Medicaid back up. So he didn't close his Medicaid down south and open his Medicaid back in New Hampshire. So he had no insurance coverage.
That's why the guy was so worried about his paperwork.
Yes.
I mean, I do, because it's like, I can see
Yeah.
where the guy was like, my paperwork, and I would have been, okay, I will take it, you go.
Yeah.
Because that makes people literally crazy. I
It
got
does.
this form for this, and I can't get this, and I gotta go get this, and then you keep it turned on every 6 months, and.
Yeah, and on and off Medicaid because you don't get the mail.
And,
Yep. Yep, exactly. So there is a very happy ending to this story. This gentleman then ended up getting readmitted to the hospital when he came back up here, ran out of insulin. They started his insulin back up. We got his Medicaid turned back on. And finally, when they discharged him from the hospital, they discharged him to mental health supportive housing. It made all the difference in the world. So then what happened was, he had a cardiac issue, yeah. But, so then, now, he's in supportive housing, he's taking his medications as prescribed, he's exercising every day, he's also taking his insulin every day. We prescribed his insulin based on, sometimes he'd take it, sometimes he wouldn't, he'd take it at all different times. Guess what happened? His blood sugars went too low. Because now he's actually following the plan, he's taking the insulin, he's exercising. So now we had to readjust his insulin, because he actually ended up, I think, in the hospital because his blood sugar went too low at one point. So what's happening now is he's in the supportive housing, he's eating 3 meals a day, he's exercising every day, he has access to a pool, he's actually swimming. He comes to the appointments with his case manager from mental health center, and when he leaves, not only does he have the plan, but he signed a release so his case manager has the plan as well. He keeps his appointments, he's not missing appointments, and he has been admitted to the hospital a couple of times, but it's been 3 days and the infection did not spread to the bone. They were able to treat it with oral antibiotics, and he's been staying on his medications. None of this changed until he had the supportive housing. So he had the medical care in place, he was addressing his behavioral health, his mental health, and his substance use disorder. Until all of that was in place, this was just in and out, in and out, in and out of the hospital. Mary says, why didn't that happen on his first admission? I'll throw that out to all of you. Why didn't that happen on his first admission? The housing is very limited. Yeah, the supportive housing is extremely limited.
Section 8 is like a 9-year thing. So, yeah.
I don't think it's that different in Manchester.
So, I was just sitting here thinking numbers-wise, all those hospitals, in and out, in and out, how much housing do you give them? They could have rented a place.
I don't know if you can hear in the back, but what she's saying is that all of that in and out, and how much money was spent in the hospital definitely could have paid for the housing, yeah. And if the other thing Manchester doesn't have either is respite care, so they're really, that's the other sort of piece with the going to a skilled nursing facility. There's no respite care in New Hampshire, so there's no skilled level of care that could be provided for people who are experiencing homelessness.
I'd love to see like assisted living for the mental health. Wouldn't need full nursing care, but just someone who's there all day that can just be available triaging things.
Assisted care for the mentally ill, yeah, go ahead.
I'm sorry if I missed this part, but what was his drug of choice for substance use disorders?
It was alcohol.
Have anything to do with his diabetes?
Certainly someone with alcohol, that's going to affect their diabetes for sure. Actually, any substance. Probably one of the largest challenges I have as a certified diabetes educator is working with people who have type 1 diabetes. So usually we used to call that juvenile diabetes. Multiple admissions for what we call DKA or diabetic ketoacidosis, which can be life-threatening, who are also struggling with a substance use disorder. And
Did he get any treatment? Through any of the processes that were in between him being hospitalized?
he had never gone to any inpatient treatment for his substance use. I don't think it really got addressed until he was in the housing.
So that's a problem, because a large part, if he was not able to not drink, the non-compliance comes from that as well.
Certainly, adhering to a plan and medications is more difficult when you're experiencing a substance use disorder for sure.
But also, I would say being able to comply with treatment, substance abuse treatment is much harder when you're homeless as well. Like,
Yes.
so if they didn't have a discharge plan for substance abuse treatment, it wouldn't have made any difference. Yeah.
So I will leave you with one of my favorite quotes. This is from Dr. Martin Luther King, and what he said is that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. I'll take any questions. Yes.
How does your clinic approach billing for the integrated providers? I hear you say you have an LCMHC, you have a master social worker. You bill for these services. One of the barriers we're coming across is we can only have an LICSW. We have to bill psychotherapy codes because the health and behavior assessment codes aren't accessible to anybody but a clinical psychologist. And so if you're on a fee-for-service model, how do you approach that, or is that worked around?
So actually, no, they do bill. We have the Master's Prepared LADAC and the LICSW both bill. And billing's a little bit different for us because we're at FQHC, so we get a federal rate that we're paid, not so much a fee for service. One of the things we're running into is we've just started our medication-assisted therapy program, and the FQHC rate for medication-assisted therapy, we're finding out, is not what we're used to for what we're usually getting for an FQHC rate. It is a fee-for-service rate, so it's actually a different rate.
Because with the LCMHC, they can't bill Medicare, so we can't have an LCMHC in an integrated position because a certain population of patients will be billed and a certain population of patients will not be billed, and you just can't provide different services. So I just curious if you had any.
And I will say our largest insurance is Medicaid. We have a few Medicare, but we have a pretty small Medicare population. The majority are Medicaid.
Thank you.
We also have, I guess it's the benefit of a grant. We are also federally grant funded, so some of our services are, at least we got them off the ground through grants, federal grants.
How long did it take your clinic to add the PhD3 into your EMR system?
So the question is, how long did it take to add the PHQ-3 into the EMR system? We ended up having to do a workaround. So the way that we're tracking it is the PHQ-2 is in the EMR, so we put in the first two questions in the PHQ-2, and then we open up the PHQ-9 in the EMR, and answer, just use
Say it
question
right
9.
in.
Yeah. Well, actually, it's all radio buttons, because they're all considered, in our electronic health record, in order to report on things, they need to be what we call OBS terms, so they're like specific things that write to tables, so that then you can report on them. So, question 9 is an OBS term, so it'll write to a specific table, so we can report off on the PHQ2 plus question 9. And that's how we're documenting the PHQ3. And our workflow is, we do the PHQ3. If someone scores, and the PHQ3 is given to the patient by the nurse. If they score 3 or less, and they score 3 or 2 or less than 3, and they score 0 on the last question, it's negative and we finish screening. If they score 3 or higher, or anything other than 0 on the last question, the nurse will hand the person the entire PHQ-9. They'll complete the PHQ-9. The nurse documents the PHQ-3, gives the PHQ-3 and the completed PHQ-9 to the behavioral health team. The behavioral health team meets with the person while they're in the clinic that same day, reviews the PHQ-9, does a depression care plan if they scored above 10 or above on the PHQ-9, or anything other than 0, does a suicide assessment, documents it, and then that's actually what we report out back to the feds. They're looking for anyone that doesn't have a diagnosis of depression. You screen them with a PHQ, they say 2, we use 3. And then if it's positive, you screened with a PHQ-9. If that's positive, you have a depression care plan in the electronic medical record.
Okay.
Does that answer?
Yeah, so I'm from Exeter, and we had the Zero Suicide Conference last, I think it was a year ago, and that's what we run across, is core physicians doesn't want to have that in, because they don't want to answer the question.
And we ran into the same thing. Yeah, we ran into the same thing.
They just need a plan. When it is this is
Yeah.
what you do.
So we were thinking about adding that training in, to use health streams, to add that in, so, because I think we only have actually like 5 doctors and core physicians come to the conference. So, maybe I didn't answer the question. You asked it.
One of the other nice things we have here in Manchester is the mobile crisis team. So if it doesn't happen very often, but once in a while, we might not have a behavioral health person in the clinic. They may be at our other site. And we have the flyers for the mobile crisis team. So one of the nurses, we're comfortable with working with someone with the mobile crisis team, or even calling. We've had the mobile crisis team actually come to the clinic, and they'll assess people in the clinic.
What are you using any technology for it, or are you doing different workflows? Can you talk a little bit about how you
Sure. She's asking about the closed loop referral process. So we are working with the IDN4. There is some technology that is not rolled out yet that we are looking at. One of the things we have is this CHAN, this group that kind of goes across, and what's interesting about CHAN is they go across IDNs as well. So whatever we end up kind of figuring out will be done through CHAN, and then CHAN it'll be shared across all the IDNs that are, one of the things we talked to the other day, and I'll get you in just a minute. One of the things I saw the other day was a demonstration. There's some software now called, it's ADT, Admission, Discharge, Transfer. So there's a number of states that are working with this ADT, or Admission, Discharge, Transfer. So Some of that technology, I think, is going to be used for the closed loop referral as well. We're really, really early in the process. Right now, we're still in the process of, it's a wish list. Right now, we're still faxing referrals. Yes?
Rick Silverberg from Region 5, Health First Family Care. We're actually the pilot site software called CMT.
Yeah.
Which is the piece that all the IDNs, except for Region 6, are using. So the way that software works is if you're part of your IDN, and you have someone who acts like a case manager or care coordinator, they can get a logon and a password through your IDN administrator, and you can be part of that project. CMT has been going around the state doing the training sessions over the past month. And we've got ours implemented now for about 2 months, and it works great. You could do a shared care plan, you could do a closed loop referral, but it's all a matter of the software can do it, but some of the staff still don't want to do it. So you gotta convince them it's worth the effort.
What I've seen, and I saw the CMT software about a week ago, one of the big hurdles with that, I think, is going to be the patient privacy and making sure all the releases are in place, depending on what you're sharing.
The other part of it is, we declared ourselves a CFR 42 Part 2 agency.
Yeah.
We've got 7,000 patients. There's only 2,000 of them that are SUD. We just do that shared release for CFR 42 for everybody. That eliminates all the problems.
The 42 CFR Part 2 release will go for everyone, and we're looking at doing the same thing.
So my question to that is, what is your workaround if somebody opts out? If they don't consent to that, then they
can't share it.
It's my understanding of the way it works is you have an attributed population of patients, and you share that attribution list with CMT, and that's how you actually end up getting the data. So if someone is opting out, they wouldn't be shared with that attribution list.
Well, there's also a place in CMT where you can change it afterwards, say they opted out.
And one of the big benefits I saw of the CMT2 is the ability to go into the portal, and you actually can see which of your patients are hospitalized or were hospitalized within the last 3 days.
So CMT, so I'm Valerie, and I work for Martin Stockton over at the Learning Collaborative. And so CMT is working with 6 of the IDNs, it's Collective Medical Technology, and they do have the event notification system, and they have the shared care plan. Some of the IDNs are working with other softwares for closed loop referrals, like I think IDN 1 is using Unitas, or they're working on. So there's a lot of different softwares out there, particularly for the closed loop referral. But CMT is definitely working on the privacy issues. They've already worked through some of these issues, and so it's not as big of an issue now as it was originally. So there's a lot of things happening with the IDNs, and most of the IDNs are working together with the same vendors, so that makes it helpful too.
And what's nice about that is it's working with different electronic health records and different electronic medical records, so that. What else? Still got about 5 minutes if anyone has a final question. Well, thank you all very much. Appreciate it.